need to continue our campaign to make people aware of the importance of influenza vaccine. And we all know the shortfalls of influenza vaccine. It is not as good as some other vaccines in terms of vaccine effectiveness, but it is the best prevention that we have available and the best way to avoid significant problems. So I want to now, in slides starting on 22, go through the story of what happened to the live attenuated influenza vaccine and let you know when we might expect that vaccine to come back under recommendations in the United States. So slide 23 shows you the data from the 2015-16 season. So that was the season before the one that we're just finishing. This is a study that's done every year by the CDC, but through what's called the Influenza Vaccine Effectiveness Network. And this study takes people who present to physician offices with respiratory illness and get tested for influenza. And so it then compares the level of immunization in those who test positive versus those who test negative. And if the vaccine is working, people who test positive for influenza are less likely to be immunized. And if people test negative, they're more likely to be immunized. And this particular figure shows the estimated vaccine effectiveness for children between 2 and 17 years of age, comparing on the left-hand side of each panel the live attenuated vaccine, the nasal vaccine, versus the injectable vaccine on the right. So overall effectiveness during this 2015-16 season was 62% for the injectable vaccine, but only 9% for the nasal vaccine. And breaking down specifically for effectiveness of H1N1, it looked like it was even worse than that. It was essentially had no positive benefit whatsoever. The next slide, which is slide 24, shows that this was not a new phenomenon. This had actually been seen for 3 years in a row. The reason that no change was made after this was seen for the second year, that is 2014-15, is that neither vaccine worked very well, as you can see, with the injectable vaccine only having an estimate of 15% effectiveness. So the CDC waited for 1 more year to again test this hypothesis. And as you can see, this is something happened between 2012-13 and 13-14 season. That's when the effectiveness of the nasal vaccine dropped. So that's where we stand at this point. And as a result, the CDC made this statement: in light of concerns regarding low effectiveness of influenza A, particularly against H1N1, the live attenuated influenza vaccine should not be used. Influenza is extremely complicated, and we are still trying to figure out what happened to the live attenuated vaccine. The company made a presentation to the ACIP in February and explained part of the story, which had to do with high temperatures affecting the conformation of the vaccine protein that seemed to be specific to the strains of H1N1 that were put in the vaccine, beginning with the 2013-14 season. And then a second problem having to do with pH susceptibility. So the specific strains that were going into the vaccine seemed to not hold up as well, and that's the current state of what we know about the failure of the vaccine to work. But we still don't have all the answers, and we particularly don't have the answer about the impact of prior immunization. The United States was probably the first country to routinely use the live attenuated vaccine in all children. So we have a lot of children who've had multiple doses of vaccine, and there is a remaining question about whether multiple previous doses may blunt your immune response to subsequent doses. So I think it is very unlikely that the LAIV will be recommended in the upcoming season because we don't have much data on response to H1N1. The vaccine is still being used in other countries, and we hopefully will get some data from there. But this last influenza season, as I've already said, was mostly H3N2. So we're not going to get much data on H1N1. So stay tuned, but I do not anticipate that the live attenuated vaccine will be recommended in the coming season by CDC. The other two bullet points on this slide are just to illustrate the overall complexity of influenza and our lack of complete understanding of the immune response. So, for example, there was a study published just in February of this year and referenced at the bottom of this line that showed that the monovalent H1N1 vaccine that we used way back in 2009 showed a fundamentally different immune response than our standard trivalent vaccine. So we really have a lot to understand about how influenza interacts with the immune system, particularly with repeat doses. So stay tuned for any changes to the LAIV recommendation. Okay, with that, I'm going to jump to pertussis. So I'm on slide 27. There's nothing really new with pertussis, except we are all experiencing significant outbreaks of pertussis. The left-hand figure here shows California's experience with a big peak in 2010, another one in 2014. The last couple of years have been quiet in California, but the early signs this spring are we're starting to see significant increases in cases again. So pertussis is here to stay, and I think on our previous webinar we covered the reasons for that, so I'm not going to go over that again. But we continue to emphasize the importance of a pregnancy dose of Tdap with every pregnancy, because at this point that's our best strategy to prevent infant cases, and it's the infants who get severely ill and sometimes die with pertussis. So that's the focus of the current public health program. And jumping to slide 30, which shows the reason for this. On the left-hand panel, we see the spike in antibody that you get after doses of Tdap, but that antibody level pretty quickly drops down so that a year after vaccination, it's back down to a baseline level, which then gradually tapers off over subsequent years. So the goal of pregnancy immunization is to immunize mothers while the baby is still hooked up to the mother, so that they get the benefit of transplacental antibody. So they are born with a high level of antibody, and that protects them during those first couple of months of life, during which they're so susceptible to severe pertussis. So it's not nearly as good to immunize after pregnancy or before pregnancy. We really want to immunize during pregnancy. Slide 31 is yet another example of a study that shows how well this works. So this was published just this year in Pediatrics by the Northern California Kaiser Group. And if you focus on the left-hand part of the figure that shows 2-month follow-up vaccine effectiveness, overall, when women are immunized during pregnancy, at least 8 days before the baby is delivered, the vaccine prevented pertussis in 91% of babies. So that's a very high vaccine effectiveness. You'll look down below and see that if women are immunized before pregnancy, not as good an effect, and if they're immunized afterwards, similarly, much lower vaccine effectiveness. So we really need to get women to get immunized. We need them to be comfortable getting immunized. We do know that the vaccine is safe in pregnancy. And slide 32 is a recent study which further illustrated this, a study of over 50,000 women who received Tdap during pregnancy and looking for adverse events. And if you just look at the adjusted rate ratios on the right, there is no significant safety concern across a whole number of possible side effects from the vaccine that were studied and included in this study. There is no increased rate of side effects in women receiving Tdap during pregnancy compared to those who are not. So that's the good news. The vaccine works. The vaccine is safe. The challenge is to get it into pregnant women. Slide 33 shows how we're doing, at least based on national data. With the green section of this bar graph showing the number or percent of women getting immunized during pregnancy. We're up to 42% in 2015. We're probably doing a little bit better than that now, but we still need to push and get our obstetrician colleagues and family physician colleagues who care for pregnant women to get that immunization administered. So that's all I'm going to say about pertussis, but I think pediatricians can play an important role in this whole story. Let's move on to slide 34, where we're going to talk about mumps. Who thought we would be talking about mumps in 2017? And that historical photo on the left was a sign about the quarantine that people used to be put under when they had mumps. Greg can't come out to play. Well, we had a new version of that last year with the outbreak in the National Hockey League. So that's Sidney Crosby, who got mumps and therefore couldn't come out to play. And there was actually a small outbreak in the National Hockey League, as there have been in a number of other places, including college campuses across the United States. So slide 35 shows how mumps is making a comeback in the United States. Certainly we're not anywhere near the historic levels where we had hundreds of thousands of cases per year, but if you look at the inset in the upper right, there we've had a couple of big years in the last decade or so. The most recent data from 2016, we had close to 6,000 cases of mumps in the United States. So mumps is still around, and mumps certainly can cause outbreaks. Just a reminder for those of you who haven't seen mumps in a long time, we usually only recognize it when parotitis develops and the characteristic swelling. But that, I should remind you that that does not happen in about a quarter of cases. So it's very difficult to diagnose mumps without that, because otherwise it's a low-grade fever and some myalgia and headache. It could be pretty much anything. So be on the lookout, and public health will let you know if you have mumps in your community. We have to, of course, be careful to distinguish it from lymph node swelling, which is a much more common problem. And a reminder from the figures on the right, the pictures on the right, that it isn't always just the parotid gland that's involved. There are sublingual and submandibular salivary glands that can also be infected. So the swelling can actually be inferior in the submental area. It isn't always just over the angle of the jaw. Complications of mumps are orchitis, encephalitis, and hearing loss. So it is still a significant disease that we need to deal with. Slide 32 goes through the background for why this is happening. Basically, mumps vaccine is less effective than measles vaccine, so it's combined as MMR, but the mumps component is only 80% effective with 1 dose and 90% effective with 2 doses. So less effective than the measles component. And on top of that, we now have data that vaccine immunity can wane over time. Mumps is highly contagious, so once it gets introduced into a community, outbreaks are very common. And many of the recent outbreaks have occurred in people who are fully immunized, that is, have had 2 doses of MMR. So this particular story is not a story of vaccine refusal and people not being immunized. It's a vaccine that doesn't work as well and has waning immunity. And that's why a 3rd dose of MMR is sometimes being recommended by public health when outbreaks occur. So you'll, if you have an outbreak in your community, don't be surprised if public health starts recommending to your patients that they come back to you to get a 3rd dose of MMR. But that would, at this point, only be recommended in an outbreak situation. All right, I'm going to jump on to meningococcal disease, slide 38. In fact, let's just go to slide 39. Meningococcus is probably the most confusing thing that we're dealing with regard to vaccines. And this slide illustrates the differences. So first of all, we have 2 very different vaccine types, the meningococcal ACWY and meningococcal B. Each of those types has 2 products and 2 brand names to keep track of. There are very different recommendations currently for these 2 vaccines. The ACWY vaccine is the one we're routinely giving to adolescents. It is also recommended for younger, high-risk individuals, including infants, all the way down to 2 months of age. The meninge B vaccine is not routinely recommended for any population except those who are at high risk, and it is not recommended for infants, even high-risk infants, and we'll go through that in subsequent slides. The ACWY vaccine that is recommended for high-risk individuals, younger individuals, actually has different recommendations for the two different products, so I'll go through that, and that has to do with vaccine interference. And then lastly, for meninge B vaccines, which we're giving to high-risk groups, we have two different products. They cannot be interchanged because they're fundamentally different in their composition. And on top of that, they have different schedules with different intervals. So it can be very confusing to sort of navigate meningococcal vaccine. Slide 40 summarizes the different products. We've sort of touched on all of this. The meninge B vaccines just licensed in 2014 and 15. There is a new recommendation for the MenB FHBP, which is the brand name Trumemba. That vaccine can now be given as either a 2-dose or a 3-dose series. I'm not going to spend much time on that because it's not recommended for young children in for any indication. And so since we're talking about infant immunization on this webinar, I'll save that for another time. But just to make you aware, there is a new 2-dose option, but it isn't for all people. So you need to be careful to look at the details of that recommendation. Okay, let's jump to slide 42, which summarizes the recommendations for the MenACWY vaccine in high-risk groups. Now, and although this is not a new recommendation, you need to make sure that you're on the lookout for those rare patients in your practice who have complement deficiency, who have asplenia, either functional or anatomic. During outbreaks of those serotypes, the health department may recommend vaccination for some populations. For travel, this vaccine is recommended for people who traveled to high-risk endemic areas, which are mainly sub-Saharan Africa and Saudi Arabia during the annual Hajj pilgrimage to Saudi Arabia. For these high-risk groups, this is a 2-dose series, and booster doses may be required every 3 to 5 years, depending on the age and the indication. So again, the details get pretty confusing, but just I think it's sufficient to remember that there are certain high-risk groups who should get MenACWY. One of those groups is specifically HIV-infected individuals, so slide 43 summarizes this recommendation, which was published just last year in 2016. Individuals with HIV infection have a significant increased risk of getting meninge disease, although interestingly, most of that disease is serogroup C, W, and Y, and not serogroup B. So there is no specific recommendation for HIV-infected people to get meninge B vaccine, but there is a recommendation to get the ACWY vaccine. And this vaccine this recommendation extends all the way down to 2 months of age. So infants who are at high risk, which is the same group I showed you on the previous slide, you should start immunizing if you recognize them as high risk as early as 2 months of age. And the number of doses you need and the intervals depends on when you start the vaccine. And so I would refer you back to this MMWR publication, which goes through the details of that recommendation. Slide 44 talks about the difference between the two available ACWY vaccines. The ACWY-D vaccine, which is Manactra, is licensed currently down to 9 months of age. The MenBio vaccine is licensed all the way down to 2 months of age. So for very young infants, only one of the vaccines is recommended. On top of that, the MenACWY-D vaccine has been shown to interfere with pneumococcal conjugate vaccine immune response. It's not a major interference, but there is some decrease in the pneumococcal vaccine titers. And this is particularly important for children who are asplenic, because asplenic individuals are at very high risk for serious disease from pneumococcus. So as a result of that, this particular vaccine is not recommended for children with asplenia or children with HIV infection below 2 years of age, and that's because of vaccine interference. There's also been a more recent study showing interference of this vaccine with DTaP vaccine. So once again, children with the increased risk for meninge disease should be given, you don't want to give those two vaccines at the same time because of interference. Slide 45 just reminds us that there is a similar recommendation for high-risk individuals for meningitis B vaccine, but this recommendation only starts at 10 years of age. So for young infants, there is no recommendation for use of meningitis B. But starting at age 10, those same high-risk groups are recommended to get meningitis B vaccine, as we've been through with meningitis ACWY. In the interest of time, I'm going to skip forward to slide 48, which just is a summary of the new 2-dose recommendation for Men B FHVP, which is Trumemba. This vaccine was, the vaccine license was updated in April 2016 to allow 2 doses instead of 3. This is the vaccine that started out as a routine 3-dose series. Now you can use it at 2 doses, but only for healthy individuals, and that's an important distinction. Those people who are at increased risk need to continue to get 3 doses because the immune response to 3 doses is somewhat better than 2, although 2 doses is adequate for healthy individuals. For those at high risk, including during outbreaks, 3 doses is still recommended. So again, this is just part of the overall confusion around meningococcal vaccine. Okay, I'm going to finish up talking about pneumococcal vaccines. There's no new recommendations here, but if you go to slide 50, just a reminder that we have 2 different pneumococcal vaccines available, the old polysaccharide vaccine that was given routinely to seniors and the conjugate vaccines, which we've now been using routinely in young children for many, many years and have led to a significant decrease in the overall rate of pneumococcal vaccine. Now, the important point for today is that some populations need both vaccines. So under slide 51 lists high-risk children and adults, immunocompromised individuals, again, children with HIV infection, children with malignancy, nephrotic syndrome, they need both vaccines, and anatomic or functional asplenic individuals as well. Children with hearing loss who've received cochlear implants are at increased risk. They need both vaccines, and then CSF leaks. And again, which populations need 2 doses and who needs boosters is very confusing. If we go to slide 52, this is a table from the Red Book and is also published in the journal Pediatrics in 2014, which allows you to quickly look at which populations should get the PPSV polysaccharide vaccine starting at 2 years of age. It's not recommended below age 2, but starting at age 2, all of those populations listed there at high risk should receive the polysaccharide vaccine after they've completed their Prevnar series, and some of them, a subset of them, need a second dose of PPSV23. And that's all spelled out in the Red Book chapter or in this publication of the policy in pediatrics. So yet another example of the complexity of vaccination recommendations currently for young infants. So let me summarize, particularly since we had a break in the presentation and I'm not sure whether you heard all of my points. The important summary from today: the birth dose of hepatitis B should now be given at birth, not later, and within the first 24 hours. Infants who need to be immunized because their mothers are infected, and if you document they don't respond to the first 3 doses, you can give a single dose revaccination instead of revaccinating with 3 doses as we previously did. Despite lobbying of your young patients, we still are not recommending the nasal vaccine for influenza until we better understand what happened to the effectiveness of that vaccine. As pediatricians, we need to continue to advocate for Tdap immunization during pregnancy because that's the best bet for preventing infant disease. Stay tuned for mumps outbreaks in your community and possible recommendations from your health department to give a 3rd dose of MMR. Remember that meningococcal ACWY vaccine is recommended for a small subset of high-risk children in your practice beginning at 2 months of age, but meningitis B vaccine is not. And then don't forget that some populations need both of the pneumococcal vaccines and that there's a table in the Red Book that can help you sort that out. So I hope you got most of those points despite our technical difficulties. I'm going to turn it back over to Anne to field questions.
Hi everyone. Once again, I just want to apologize for the technical difficulties that we had. I just want to reiterate that I will be sending out a copy of the PowerPoint slides to everyone, so you will be getting everything, completely full and non-disrupted like we had earlier. So just want to turn it back to the webinar then, just to remind everyone, for questions that you have, you can enter them in on the control panel, which is usually going to be on the right hand side of your screen under questions, and then you can just type it in, and then I can go ahead and read those out to Dr. Sawyer. So the first question that I have is, do family members need a Tdap vaccine with every pregnancy also?
No, the current recommendation is for family members and everybody, for that matter, to get 1 dose of Tdap at some point in their life, of course, routinely given in adolescence at 11 to 12 years of age. But because of the very short duration of immunity, there is no recommendation for booster doses, including when there's a new infant coming into the household. That strategy is not very cost effective, and it's not nearly as effective as making sure the pregnant mother gets immunized. So we've sort of shifted strategy over the last 5 years, and the emphasis is on getting pregnant women immunized, and that way the baby is born with a protective titer no matter who around them might come home with pertussis.
Okay, and then another question that we have is, theoretically, if a kid will be moving to a country where there is a recommendation for Men B, how do we do that? Why are they given elsewhere?
So the whole public health decision about whether to give meninge B is dependent in part on what the local epidemiology is. So in the UK, they have different rates of disease than we do, as an example of a country that is using meninge B vaccine, all the way down to infancy. And it also reflects the public health approach to cost effectiveness and how that should influence policy. In the United States, we're still looking carefully at meninge B vaccine. We're getting more data about safety and effectiveness and how long the immunity lasts. So we may see a change in recommendation, but at this point, it is not being recommended routinely, and certainly not for infants. Having said that, as I think pointed out by the questioner, there are countries giving it, and the schedules for administration for that vaccine are available from those countries, and you could just follow that recommendation if you needed to get a young child prepared to move to a country where Men B is being routinely used.
Okay, and then I think there's a follow-up question to that, was also, if the TD is not available, what then? Many colleges are requiring it.
Sorry, which vaccine?
It said TD, but it might mean Tdap.
So yeah, there are some colleges are free to make their own vaccine requirements or recommendations for their students. Some colleges are recommending meninge B vaccine. If this questioner has had the experience that colleges are recommending a booster of Tdap, I didn't know that was happening, but I could imagine it could be happening. We do at least have safety data from other countries that have done some revaccination, and revaccination with Tdap is safe, and we know that also from the United States data on pregnant women, where many women have received more than 1 dose with subsequent pregnancy. So it's a safe thing to do, but again, not recommended in the United States routinely. But if a college requires it, it's certainly okay to do for that reason.
Okay, let's see. Does anybody else have any more questions? I think that's about all we have. So, Peggy just said that. So she said TD. She said she can't buy TD and that it's unavailable. Are you familiar with a TD vaccine, Dr. Sawyer?
Sure, TD vaccine has been around for years. I didn't know that there's either a shortage or a decrease. If, in fact, you are in a position where you need to give TD and you don't have TD, then sure, it's fine to give Tdap instead. The tetanus and diphtheria components are the same, and will certainly boost that immunity, and you'll get the added benefit of some new pertussis immunity, albeit short-lived. So yes, you can substitute Tdap for TD if that was the question.
Okay, so I'm not getting any questions. I think we'll, just another one came in. And so this question is, in our clinic, we have been educated to administer Bexsero routinely to teens, even if it is not high risk. Is this inaccurate?
There is what's called a permissive recommendation from CDC, also called a Category B recommendation. And what that means is that the individual providers can make their own determination of which patients should get the vaccine, and it's okay to give. But the distinction is it's not routinely recommended for everybody. So there's not the expectation that every adolescent in the United States get meninge B vaccine. However, if a provider wants to do that as part of their practice, that's okay. If individual families request the vaccine, it's certainly fine to give them the vaccine. Just as part of the education of that family, I would make sure they realize we still are learning about how effective that vaccine is against the different serotypes. Some data suggest it's not as effective against multiple types as is the other ACWY vaccine. We're still getting data on how long the immunity lasts, so one question is at what age you should give it. Again, the Category B recommendation says starting at age 16 to 18. If you're going to give it, that's probably the best age because that's the beginning of the higher risk period for older adolescents and young adults for all meningococcal disease, whether it's type B or the other. So it's certainly okay to give. It's just not routinely recommended by CDC or AAP.
Okay, and then the final question that we have before we're going to go ahead and wrap this webinar up is for a kid who has refused DTaP, how often can I give Tdap once they're over 7?
So again, the recommendation for routine use is only once. You give them a single Tdap after they've completed the DTaP series. And so starting at age 7, if you need to give any vaccine in that family, you would give a Tdap as opposed to a DTaP. But the recommendation is just to give the single dose, not repeated dose.
Okay, awesome. I think that about concludes our webinar. Thank you so much, Dr. Sawyer. And I know I sound like a broken record by now, but I'm so sorry to you and everybody else about that technical difficulty that we had in the middle of it. But everything else, it was wonderful. It was incredibly informative, I know, at least for me. And I just wanted to thank you and everybody else for participating in our webinar for National Infant Immunization Week. If anybody has any further questions, they can feel free to email me directly and I'll try to get it to the correct party to get that question answered. So I'm going to go ahead and conclude this webinar for everyone and just wanted to let everybody know to sign up for any of our future webinars and that you will be receiving a copy of the webinar slides, a link to the evaluation, and the recorded webinar by the end of business day tomorrow. Okay, thank you so much again, Dr. Sawyer, and I hope that you have a wonderful day.
Thank you.
Thank you.